Alright guys, so we'll have it and talk about autosomal dominant and polycystic kidney disease. So I've spoken about the other one, and that other one is basically the childhood type. Okay, it's basically the childhood type, right? So let's talk about the autosomal dominant type, which is like the adult type of polycystic kidney disease. So first of all, autosomal polycystic kidney disease is a genetic disease that causes what? Fluid-filled cyst, okay, to grow in your kidneys. Can you see all those round stuffs? It's just a way of representing a fluid-filled cyst. All right, polycystic. Poly, that means there are many. Okay, so we say that it is also known as adult type because the symptoms usually appear between the age of 30 to 50. This one is the autosomal dominant one. All right, it's dominant. Even if you escape it in the childhood, it will come later on when you're big. All right, so it is a hereditary disorder. It's commonly affecting about 1 in 400 to 1,000 live births. It accounts for about 5 to 10% of chronic renal failure, right? They actually requires transplantation or dialysis for management. It is autosomal dominant with high penetrance. Okay, so it's usually bilateral. Okay, usually affect the two kidneys, right? Two kidneys will be affected, but unilateral cases have been seen. So the cysts usually involve only portions of the nephron. Okay, so mutations are seen in gene XM. Right, the genes that are mutated is the XM. Right, so 16p. Alright, that's like at the 13.13. This one is just trying to show the exact this thing. If it is at the gene XM 16p 13.3, it is a polycystic kidney dominant disease type 1. But if it is at the 4p21 chromosome, it will be the type 2. Alright, so type 1 is 85% of the cases, while type 2 is very rare, 15% of the cases. So this type 1 is associated with renal failure in less than 5% by 40 years, and there'll be almost 95% of renal failure when you are like 40 years, right? So the type 2 is less than 5% at 50 years and about 45% at 70 years. So the type 2 is more friendly. Okay, so guys, that's it. Pathogenesis. Um, well, different mutations have been described. Okay, so polycystic kidney disease type 1 encode what? A large integral membrane uh, protein polycystin 1, which has multiple transmembrane domains and a short cytoplasmic tail localized at what? The tubular epithelial cells at distal nephron. However, the polycystic kidney type 2 has a gene. Okay, this one has talking about the gene now. It has a polycystin 2, alright, an integral protein localized in all segments of the renal tubules. Do you understand? So this one is talking about the genes. Okay, it's mutations in the genes. Okay, I forgot to put, this is a polycystic kidney disease 1 gene. Alright, so I think that's it. The recent evidence, polycystin 2 acts as a calcium permeable cation channel. Alright, so is actually the basic defect, right? So disruption in the regulation of intracellular calcium levels will result when there's a mutation in that gene. And recent evidence shows that polycystin 1 forms complexes with polycystin 2, right? So, right. So, pathogenesis of this autosomal dominant polycystic kidney disease is hinged on this process of cyst formation, right? Now, when the cysts are formed, they progressively what? Expand, okay? And there's progressive renal damage, right? Current thinking is linked between what? Polycystins, right? So polycystin 1 is like cell to cell or cell matrix interaction. Is important in tubular epithelial cell growth and differentiation. So that's why if there's now a mutation in that polycystin 1, you now have cyst instead of a normal type of what? Tubular cell epithelial growth. Okay. So cysts are frequently enlarged by active fluid secretion from the lining epithelial cells. Cysts also develop as a result of what? Abnormality in cell differentiation, right? Associated with cell proliferation and increased apoptosis. Okay. There's transepithelial cell fluid secretion, and there's remodeling of extracellular matrix. All of this will result in what? Cyst enlargement. Okay. So cyst fluids harbor mediators from the epithelial cells that encourage inflammation. All right. The cysts are formed. There's now secretion of active secretion of fluid from the linings of the epithelial cells, and the cells have what? That's what you call the pro-inflammatory what? Mediators. Those are the substances that actually what? Encouraging inflammation. So molecular basis by which mutations of this polycystic kidney 1 gene and polycystic kidney 2 lead to cyst formation is still not clear, right? But polycystin 1 and 2 that form from polycystin complex result in changes in intracellular calcium level, right? So they are kind of like the second messenger, right, of calcium. So the changes in cellular proliferation to occurs, and there's an abnormal extracellular matrix. Okay, epithelial secretion together is what results into what? Autosomal dominant type of polycystic kidney disease. Right? How about morphology? Grossly, the kidneys are usually enlarged bilaterally. So this autosomal dominant polycystic kidney disease usually affects what? The two kidneys. So the kidneys will now be weighing up to like 4 kilograms. I see how big this kidney is. Now because of cyst and because of deposition of fluid, or you understand, it makes the kidneys more heavy. So the external surface will be mainly cyst. Okay. So looking at the microscopy, now functional nephrons will be seen in between the cyst. Now the cyst will be filled with clear serous fluid or turbid fluid, or sometimes it's hemorrhagic. Alright, so sometimes it's blood that will be seen in the fluid, sometimes it's just a clear fluid, sometimes the fluid will actually look very, very turbid. Alright, so clinical features occasionally begins with the insidious onset of hematuria, followed by other features of chronic renal diseases like proteinuria. Alright, and so this polycystic kidney disease is a systemic disorder. Alright, so patients tend to have what? Extra renal congenital anomalies, like extra renal, like if you inherit this condition, you also be having some problems in the body that are not of renal origin, be having problems with other organs too, right? So 40% of them, of these patients, we usually have cysts in the liver. That's polycystic liver disease, all right? So cysts occur less frequently in the spleen, pancreas, or lungs, right? Then intracranial what? Berry aneurysm, okay? Right, they also be having the subcranial arachnoid hemorrhage in the arterial cycles of Willis, alright, which in 4 to 10% of cases will lead to death. Okay, there's mitral valve prolapse. This occurs in 20 to 25%. Alright, so this is it for the autosomal dominant type of polycystic kidney disease. See you guys in the next one, which is like the adult type.